Welcome to the Global Addiction Therapeutics Innovation Day.
Thank you. We're now on to the last speaker of this session. It gives me pleasure to introduce Dr. Andrew Huhn, who is the director of the Bayview Clinical Research Unit and an associate professor at Johns Hopkins University, where he has been focusing on multimodal methods to advance treatments for people with opioid use disorders, and he will be presenting on this topic as related to substance addictions.
Okay, well, thanks everybody for being here. Really enjoying Hamburg so far. Maybe not the weather today, but the people and the scenery. So, yep, we're going to be talking about the next generation of addiction pharmacotherapeutics. These are my disclosures. I receive research funding from the NIH, National Addiction Treatment, and formerly from Indivior. I also receive research support, not financial, but study drug and human resources from Merck. Okay, so very quickly, we're going to talk about current substance use treatment. This will be a kind of US-centered presentation of that. We're going to talk about sleep and stress and opioid use disorder and drill down into the orexin neurotransmitter system as a potential target for medication development in this space, and then future directions more broadly for substance use disorders and medication development. So what are substance use disorders? I tend to think about the diagnostic criteria in buckets, in 4 buckets. So one is thoughts, and an example of that would be drug cravings, these kind of intrusive thoughts that people have that tend to drive substance use during substance use disorders. Behaviors or activities necessary to obtain, use, and recover from opioids or any substance, the consequences of drug use, and finally, physical dependency. Is their tolerance to a substance, does it have a physical withdrawal symptom? Substance use disorders in the treatment in the United States tends to be kind of a choose-your-own-adventure. Many people first engage with their primary care physician. This is really being pushed as a point of first contact. For folks with opioid use disorder, they might receive buprenorphine from a primary care physician, or they might be referred to addiction treatment specialists such as a methadone clinic or opioid treatment program. If you are able to go all the way through withdrawal and abstain for 7 to 10 days, you could get on extended release naltrexone. Outside of those 3 medications, there's also residential treatment that is highly structured, but varying levels of medical care depending on which facility you go to. There is individual and group counseling. There are I won't say non-treatment, but non-medical treatment like Narcotics Anonymous. And I think it can be really confusing for people who are trying to enter treatment. We don't seem to have a really coherent plan for folks across the board. Another way to think about it is to think about the trajectory. In here I'm going to use opioid use disorder as an example, and the levels of care. So when we're thinking about medication development, thinking about things that we can do for people who are in active opioid use disorder, especially in terms of overdose prevention and harm reduction. If people decide that they want to enter treatment, they're going to have to make a decision to either go on a maintenance therapy like methadone or buprenorphine, or they're going to have to go all the way through opioid withdrawal to get to extended release naltrexone, or many people choose to be on no maintenance medication. So when I'm thinking about designing human studies, clinical trials in this space, I have to think about these different categories and also the different levels of care, right? Because some people are receiving residential or hospital care at first, although that's a smaller portion of the population. There are sober living environments like halfway houses, outpatient treatment that can be short-term or long-term, and also, again, the 12-step meetings or no ongoing care. And so there are several areas of opportunities as far as outcomes go. And some of these, I think we still have a lot of work to do with regulatory bodies, especially in the US, like the FDA. But the most clear-cut outcome is to reduce or eliminate the actual substance use. and also to think in terms of DSM-5 criteria. There was a great paper by Nora Volkow a few years ago thinking about, can you transition people into early remission as defined by the DSM-5, and then long-term remission as potential outcomes for clinical trials. There's also harm reduction strategies, reducing drug use, reducing risky behaviors, restoring personal and social function, overdose prevention and treatment. We always need to be thinking about co-occurring disorders. Most folks with substance use disorders also have other mental health conditions like post-traumatic stress disorder, major depressive disorder, et cetera. And then outside of those kind of formal diagnoses, co-occurring symptoms. A lot of my work is focused on insomnia or sleep disturbances, but of course also depressive symptoms, anxiety symptoms. These can linger for weeks, months, even years into treatment. And I think an overall goal is to improve quality of life, right? That's kind of a common denominator across all of these outcomes. So about 5 years ago, NIDA published a paper showing their 10 most wanted medication targets. I was really happy to see this because orexins were at the top of the list, and I had just started a trial on a dual orexin receptor antagonist. But there are many other potential targets. And part of the reason I became so interested in the orexin system is not only because there was a new medication on the market that was the first medication to actually act on that system, but also the relationship between sleep disturbances and treatment outcomes in opioid use disorder. And in this study, we surveyed folks who had just left residential care in their first month post-treatment, and they took the insomnia severity index. And in the categories here, you can see no insomnia, subclinical insomnia, clinical insomnia with moderate symptoms and with severe symptoms. And the takeaway here is that for folks who have severe insomnia symptoms in that phase of treatment, there's about a 13-time increase in their likelihood to relapse and about a 6-time increase in their likelihood to experience a non-fatal overdose. So a little bit more about the orexin neurotransmitter system. It's a little bit unique from other neurotransmitter systems. Most of the cell bodies are located in the perifornical area and the lateral hypothalamus. There's only about 10 to 20,000 orexin-producing neurons in the brain, but they do project to many areas of the brainstem, midbrain, and cortex. Orexin signaling regulates wakefulness and the sleep-wake cycle. It also regulates food, drink, and consequently drug consumption, and also has effect on reward and mood. Orexin signaling follows a circadian rhythm, and even within a sleep cycle, orexin signaling is necessary for the, decreased orexin signaling is necessary for the onset of rapid eye movement or REM sleep. And so we had designed this study on suvorexant. Again, that was the first FDA-approved dual orexin receptor antagonist. It was approved for insomnia. There's now 3 approved for insomnia and a lot more medication development happening in this space. The premise for this was that insomnia is common, clinically significant, and often hard to treat in folks with opioid use disorder. There was a lot of preclinical evidence at the time showing the role of the orexin system in opioid tolerance, drug-seeking behaviors, and specifically in opioid withdrawal, that an orexin antagonist could reduce withdrawal. And again, suvorexant was the only drug on the market at that point for this type of study. So this just shows the design. We had folks who were actively using opioids come in for an 11 to 14-day clinical trial. The first part of that was getting them stabilized onto buprenorphine. They were then randomized to placebo, 20 or 40 milligrams of suvorexant. They went through a 4-day buprenorphine taper, and then after that it was cut off, and there was a 4-day post-taper period. Every night of this study, they wore a sleep profiler that has a 3-lead EEG system, so we can actually see sleep architecture throughout the night, much more comfortable to wear than doing a full polysomnography. At 4 points throughout the day, we collected cortisol samples. We asked questions about their opioid withdrawal, their mood, their stress, their drug craving, et cetera. And here are the kind of high-level results. So during both the taper and post-taper phase, suvorexant had a significant impact on total sleep time. So during the taper, there was actually a 90-minute increase compared to placebo, and during the post-taper, there was about a 60-minute increase compared to placebo. And just to shift over to the field of sleep medicine, they actually have targets for clinically significant outcomes for these kind of studies. So they want to see a 20-minute increase in objective sleep and a 30-minute increase in subjective reports of sleep. And wouldn't it be great if we had like an agreed upon outcome for the reduction of drug use we want to see? To say something's clinically significant, I think the field of alcohol use disorder is a little bit ahead of the rest of the substance use disorders in that regard. But the takeaway here is that suvorexant way outperformed what you would normally see in an insomnia trial. And probably because these folks are in opioid withdrawal and there's increased orexin signaling during opioid withdrawal, so the antagonist really shined in this particular clinical scenario. It also had an effect on sleep architecture. This shows the normal, quote unquote, normal amount of time spent in each sleep stage for an average 45-year-old. And you can see the placebo and the different doses of suvorexant. The biggest thing we noticed here was the increase in REM sleep as like a dose-dependent increase. We've done further analysis on this, and there is a relationship between REM sleep and opioid withdrawal symptoms during the day. Suvorexant both increased REM sleep and decreased the opioid withdrawal symptoms during this study, independent of whether or not the REM shifted. And these are the primary opioid withdrawal outcomes. So you'll notice that during the taper period, visually it appears lower. That wasn't statistically significant, probably not very clinically meaningful. The buprenorphine is already treating the withdrawal. But once we took the buprenorphine away, there was a predictable rebound in withdrawal symptoms in the folks who were on placebo, and that rebound did not occur for the folks who were on suvorexant, showing that it could independently treat withdrawal even when dosed as a sleep medication and not directly during the day. So there has to be some kind of a little bit more complex indirect effect on altering the orexin signal system during opioid withdrawal. We also asked several different questions about craving. So here we ask, how much do you want to use right now? And I think of this as like a kind of bottom-up cognitive process. There was reduced drug wanting in the suvorexant group compared to placebo. I'll also point out here, and you might notice that on the right-hand panels are the three-group analyses, and there's really no difference between 20 and 40 milligrams of suvorexant on almost any of the outcomes in the study, which is really interesting, except for the REM sleep, but there seems to be kind of a ceiling effect at 20 milligrams. We also asked folks how much they wanted to avoid using opioids right now. This is more of a top-down cognitive process. And again, people in the suvorexant group were endorsing higher levels of wanting to avoid opioid use. They felt like they had more control over their opioid use if they were presented with opioids in that moment. Another kind of top-down cognitive process. And they also reported less stress during the withdrawal paradigm. So on the top here, we show daily cortisol levels, and those were statistically lower during the taper, but not the post-taper phase. And on the bottom, we show self-reported stress. That was much lower during both the taper and post-taper phase. So there appears to be, a pretty strong effect on total sleep time. I think independently that is important. Addiction medicine has struggled for a long time in figuring out how to treat sleep disturbances in this population, but there also seem to be collateral benefits for this particular drug, probably because the orexin system is so involved in substance use disorders. Suvorexant is a Schedule IV medication in the US. That means it's comparable to a benzodiazepine or a Z drug like Ambien or Zolpidem. Looking at the human abuse potential studies that were used to determine that, I wasn't quite convinced that it had the same kind of effect as a benzodiazepine. And in this population, in this particular study, We did not find any signs of abuse potential that were greater than placebo. So on these kind of typical visual analog scales for high and for do you feel good effects, et cetera, there were no statistically significant differences. We asked about, what would the street value be? People had the street value about exactly the same as placebo, almost nothing. So again, just, this is something that we pay very close attention to, especially because benzodiazepines and Z drugs are often used non-medically in this population, and we don't want to introduce another medication like that into the mix. No real safety concerns in this study. There was an increased incidence of next day somnolence or kind of next day grogginess or drowsiness. But nothing else really stood out. I have euphoria in bold here. There was one participant in the placebo group and one in the 20 milligram suvorexant group who reported euphoria. And so as far as medications that act on the orexin system, many different directions for this. So of course, we're looking at the DORA medications in different clinical scenarios. Long-term outpatient therapy with buprenorphine or methadone. Does it help there? Are there collateral benefits on actual drug use outcomes in the field? That's a little bit more of a golden goose. But we're also interested in thinking about this, since we have DORA medications that are approved, if you could use lower doses during the day, maybe something that doesn't cause drowsiness but takes the edge off from cravings, et cetera. There's also single orexin receptor antagonists, both orexin 1 and orexin 2 that are in development. Orexin 1 receptor is much more involved in addiction-related outcomes like drug seeking, opioid withdrawal, et cetera. Orexin 2 is more involved in wakefulness. There's also single orexin agonists in development for narcolepsy, interestingly. So orexin 2 agonists that I don't think would be helpful to treat substance use disorders, but might be interesting in experimental studies. And also just in general, understanding the collateral benefits of this class of medications. So thinking more broadly, what do we need to do to push medication development in the addiction space? I think there needs to be continued investment in preclinical research, especially back translation. So there's a lot of times where kind of early on in drug development, phase 1B, phase 2A type of studies where we get certain outcomes, but we might not really understand mechanistically what's going on. That's a great opportunity to go back into rodent models or primate models and be able to do quite a bit more understanding brain and physiological function. There's advanced computational methods to identify targets for drug discovery that were discussed earlier. We can talk to people with substance use disorders. That seems like a smart idea when we're developing medications, like what are the symptoms that actually bother you, not just early in treatment, but in the long term. And think more about repurposing existing medications for SUDs. I mean, this is low-hanging fruit. If we can show in the clinical trials that it works, we can actually create a treatment paradigm that is evidence-based, not just for drug use behaviors, but across the board for mental health symptoms, et cetera. So beyond just medication development, I think these things all play together. There's also device development taking place, digital therapeutics, behavioral interventions. Regarding medication development, there's currently no FDA-approved medications for stimulant, cannabis, or benzodiazepine use disorders. Nicotine use disorder medications are generally underutilized. And while they have improved efficacy over placebo, there's still room for improvement there. Medications for opioid use disorder, which we kind of consider the gold standard treatment, are also underutilized, and there's also room for improvement in that paradigm, especially thinking about comprehensive care over the long term for these folks. Regarding device development, we're really interested in prognostic tools to objectively measure the risk of negative treatment outcomes. There's a lot of work done with brain imaging that actually got me really excited about addiction science initially. It'd be nice to revisit some of that stuff, look for therapeutic tools to directly improve treatment outcomes. Also very interested in ambulatory monitoring, using fitness trackers, which can help us on I think on the sleep and circadian side, there's pretty clear use there. And also drug delivery systems to improve medication adherence, and you're seeing more and more of these kind of depot injections, vaccines, thinking about things that you don't have to take every day, you don't have to take 3 times a day, something that you can have a delivery system that kind of keeps you in the treatment for a longer period of time. These can often be tied to phone applications that provide continuity of care. They can supplement in-person therapy for folks who have a difficult time accessing that, especially in rural communities. And these can be paired with ambulatory monitoring techniques to even, to increase the efficacy even more. And then, of course, behavioral interventions, I think, go hand in hand with pharmacotherapy development for substance use disorders, thinking more about overdose awareness and prevention, and also thinking more about individualized therapy for folks and how behavioral therapies could be individualized. And finally, just thinking about other considerations, we're always very concerned with safety, especially with new medications, but also thinking about contraindications with other commonly used medications in this population. Co-occurring disorders like HIV and chronic pain, patient acceptability, provider adoption. These are all things to consider in the drug development paradigm. And that's it for me. I want to thank everybody for being here and thank the excellent team that I've worked with.
Organized by International Society of Addiction Medicine, sponsors and co-organizers, CNRA, Indivir, Spark Biomedical, Salofa, Ethifarm, University of Minnesota, European Union Drugs Agency, UK Office for Life Sciences,